membranes on here. Now you're starting to see it bleed a little bit, and that's good. I haven't thermalized it so much that I've compromised the blood supply, but it was beautifully manageable while I'm doing the surgery. So I'm going to spread my PRF membrane underneath there to enhance the quick healing. I'm going to go ahead and I'm suturing the lip now coronally so that the lip is going to be bound down. And if there's a lot of hyperactivity here, I'm also going to be doing some Botox injections in the levator muscles to reduce the pull. Our patients are more comfortable post-surgery. Well, it's simple. We get a block depolarization of the C afferent fibers, which are the pain fibers, the non-myelinated axons. We get increased nitric oxide production, so we get a better perfusion in the area. Anything that releases nitric oxide actually releases and has an effect on the smooth muscle in the arterioles. And when the smooth muscle relaxes, the vessel dilates and the perfusion, the circulation increases in that area. How do we know that? Well, we look at drugs that are nitric oxide enhancers, such as, well, Viagra is one. And when we have a release of nitric oxide, we have much better blood supply. So lasers are Viagra for the tissue. Vasodilation is also stimulated via the histaminic and nitric oxide and serotonin response, resulting in reduction of ischemia, which is poor perfusion, and lymphatic vessels are sealed, resulting in reduced tissue edema. Photobiomodulation, you can do a whole day course just on photobiomodulation, which essentially is upregulation of mitochondrial metabolism, whether it's on the soft tissue side, in getting fibroblasts to regenerate soft tissue more quickly, or in bone to make bone grow more quickly, the laser will have a direct effect on that. How do we know that this occurs? Well, watch this case. This is a vertically fractured tooth that we're going to remove. I'm going to remove the granulation tissue. I'm going to debride this. But what happens, especially on these endodontically treated teeth, the lamina dura becomes thicker. So there's no real good microcirculation in the marrow spaces to the tooth because it's been, the pulpal tissue is removed. So now you're going to see that after I clean this out, there's really no bleeding from inside here. I'm going to take a curette, I'm going to go in there, and if I'm going to graft this, there must be good copious bleeding. You see the facial plate is gone as I press on the facial tissue here. So this calls for a good graft. But before I place my graft, I want to be sure that there's going to be real copious bleeding. So I'm going to take my laser down, and I'm not going to touch anything. I'm just going to use it in space, and I'm going to go around and around. And then literally within seconds, you're going to start to see the blood welling up from inside here. There it is. Look at that bleeding all of a sudden. That is a vasodilation of the blood vessels in that site without even touching the tissue. We get increased prostaglandin synthesis, which also has a vasodilating and anti-inflammatory action, similar to the COX-1 and COX-2 pain medications. There's an increase in beta endorphins with subsequent pain reduction, early epithelialization by accelerating fibroblast regeneration. That's photobiomodulation, upregulating mitochondrial metabolism. That's what we want to do in the soft tissue. There's acceleration of white blood cell activity, especially in the area of tissue macrophages. Those are the first cells that come into a site. They're called monocytes. Not only do they help to clean out damaged tissue, they also are phagocytotic. They'll attack any bacterial colonization that's there. And they do one more thing. They're the body's first producer of BMP, bone morphogenic protein. So if you're trying to grow bone, the fact that you have a much higher activity of these white blood cells means that you're going to get tissue repair, especially bone growth, much more quickly. There's reduction in interleukin 1 and C-reactive protein, both inflammatory modifiers. There's increased wound tensile strength in both soft tissue and connective tissue. As it's healing, it's going to heal with better strength. Increasing the intra and intermolecular hydrogen bonding in the collagen molecules so that you get better tensile strength. If you don't want your tissue to break down, you want to have a soft tissue laser as a part of this. Decontamination. When we're doing, for example, periodontal therapy, and this could be in part with oral surgery, and we're going to keep some teeth, we're going to extract some teeth, maybe place some implants, but one of the problems is the adjacent teeth can be a source of infection. That's where the bacterial pathogens are going to reside. So in these cases, I will use a double wavelength treatment of these cases. You note that I don't really need to use too much of a scaler. I do in some cases. If there's really heavy accumulation, I will scale it first, knowing that I'm not going to get all the calculus off. And then I'm going to use this radial tip so that I can remove the calculus. But that's not enough. Once I clean the root surfaces, I've got to do one more thing. I need to de-epithelialize the inner lining of this tissue, and I need to decontaminate, because if the pathogens are resident down here, that's going to be a problem for us. I'm going to do a little bit of root conditioning with acid, either phosphoric acid or citric acid, or even EDTA, which is also acidic. And then last thing I'm going to do is I'm going to use a soft tissue laser to go around and de-epithelialize this. And you'll note as I'm dragging it through, the epithelium is coming out with the tip, because I need to have a bleeding surface as I do this, as I drag this through. And as I de-epithelialize, look what's happening. It's bleeding more and more, even though it's coagulating, even though there's a little bit of vaporization here from the hot thermal temperature of that tip. We get some beautiful bleeding from these cases. And don't be afraid dragging it down. We have it on a low enough setting that you're not going to damage the dentinal surface. But look at the bleeding that we have now. That's absolutely necessary. If you want your tissue to reattach, it's absolutely necessary to have that kind of bleeding before you finish. All right, now that we have finished this is a 1-week post-op. You can see a lot of the soft tissue edema has gone down. We're starting to get a little bit of adaptation of the tissue to the root surfaces. But at 2 weeks, we get complete fill of this tissue. So in this case, it's not one wavelength. There's 2 wavelengths used here to their best advantage. Hard tissue laser to remove accretions, remove calculus and bioburden from the root surface, and then the soft tissue laser to decontaminate and de-epithelialize and photobiomodulate. Together, they have an extraordinarily powerful effect like you see here. Then there's ablation and resection. Ablation then would be very refined removal of tissue. Resection would be a wholesale removal. Now, this is not a fibroma. This is a lipoma. This is a fatty tumor that's at the surface. It's a sebaceous gland. Rather than go underneath and try to take off this little lipoma, what I do in this case is I ablate very finely. I ablate through the epithelium on the surface of this. Because what I'm trying to do now is I'm trying to enucleate the lipoma without creating a defect that would potentially cause a scar. And that's one of the things you have to be concerned about when you're doing this kind of tumor removal in a visible area on the skin. And they're generally 1 millimeter to 2 millimeters thick. At a certain point, you'll actually see me getting through the epithelium to the point where I'm in the sebaceous oil. And you're going to start seeing right there, you can see a little bit of that fatty tissue, that sebaceous oil tissue coming out. Now I'm just going to squeeze this, literally pull this right out. And once that's open and that material has been removed, that just goes and heals by itself. The lower portion actually comes to the surface, and there is no scarring post-operatively when we do this. So this is my preferred means of removing things like lipomas. Resection, aesthetic crown lengthening. You probably have seen this 100 times. That's fine. But remember, we're looking at this in terms of clinical outcome. The hemostatic response, the neurogenic response, the lymphatic response, photobiomodulation. And we want to be able to do our procedures quickly without worrying about the postoperative consequences, and then be able to go to our restorative procedures as quickly as possible. So I'm measuring the length of my adjacent central, and I want to remove as much tissue as I can to get the two centrals to be the same clinical length. Then I'm going to take a marking pen. I'm going to mark the amount of tissue that I'm going to remove. Now I'm going to take my soft tissue laser, and I'm just going to go right through that marked portion. That forms the arc for my soft tissue laser. Now you can see that relative to a scalpel, it's not as precise. But the beneficial parts of it is you got great hemostasis. You can visualize everything that you do. You can go back and measure again. If you need to remove a little bit more tissue, you can do that. So it's a very simple, easy procedure. And here's the same patient, just in a different tooth space. I'm going to do a crown extension for the cuspid, doing it the same way. But now I'm going to use the hard tissue laser. So you can see the hard tissue laser is going to be a lot more precise. You're not going to get the kind of tissue tags that you got with the soft tissue laser. And you basically just walk it along with a small flat, we call this a chisel tip. But the consequences for the tissue and the healing is the same as it is for a soft tissue laser. It's just that it's a little bit easier to visualize and a lot easier to finish the procedure. And you can plasti it just by literally running the laser tip along the surface there, just like a rotary diamond or something. Much larger tumors, such as a multinucleated giant cell granuloma or pyogenic granuloma, anything like that. Some of these things can form, and they can be quite concerning for the patient, because the first thing they're asking to see my margins when I'm doing this. Not only that, I'm looking to get a tactile sense because I can literally feel where the lesion ends and the healthy tissue remains. So what I'm doing is I'm feeling along, pushing the laser tip along, because it's pedunculated. It's got a little stalk that's there, and it's very, very easy now to resect this and remove it. And that goes right into the biopsy bottle. Now I'll go ahead and remove this. And then show you go skip that to the post-op now. This is a week or so after that, showing complete resolution of that area within a very, very short period of time. And then that tissue just granulates right back in to the point where it's covering the implant that's there. On the hard tissue side, the hematologic side, if we're going to do, these are some of my older videos that I did many, many years ago through my surgical microscope. When we're cutting bone, can we, for example, do a lateral wall sinus graft with a hard tissue laser? Absolutely. And the reason for that is that it will cut bone quite nicely, and it will actually blow the membrane off of the back of the bone. So you tend not to get any perforations when you do this. It's very, very kind to the Schneiderian membrane. But the other thing I want to show you here is that if you want to talk about the hematologic response, you see how quickly it cuts through, as long as you don't have the tip down to the tissue itself, where the power would go right through the membrane. I'm using this in what we call defocus mode. But watch what happens to the bone when I stop lasing. It bleeds immediately. So that means the settings for the hard tissue surgery are perfect. Now, you don't see the bleeding now because I'm still blowing it off with the air and the water. But as soon as I stop, look at the bleeding. You can see circumferentially that there's good bleeding here. So that is the hematologic response. It's just enough for me to visualize the surgical site. But as soon as I stop, look at the bleeding from the bone. That's the perfect setting for me. Photobiomodulation. You have in the bone, you have stabilization of cell membranes, and uptake of calcium in the mitochondria. It facilitates uptake of calcium in bone. That's extraordinarily important because if you're trying to regenerate bone, osteoblasts are responsive to what we call free ionic calcium, cytosolic calcium. The more calcium that's present, the more active they become. The more osteoblasts form from undifferentiated mesenchymal stem cells, and the more active each osteoblast is. In fact, they can get up to 500% more active on the mitochondrial side when calcium is present. ATP production and synthesis is enhanced. That's what drives mitochondrial metabolism. Growth factor release, especially with leukocytes present and platelets that are present. There's a 2 to 5-fold increase in growth-specific synthesis in normal fibroblasts, muscle cells, osteoblasts, mucosal epithelium, and that can be enhanced through the use of a laser. Finally, the debridement and decontamination. If we look at something like this is on the oral implantology side, and this is what I love to do, because one of the problems that we have in extraction and grafting, or extraction and immediate implant placement, is residual infection, especially in the apex. Now you can see the draining fistula on this left central incisor. Now the problem with this is that this tooth have been treated with a root canal. In fact, both of these have been treated with a root canal many, many years ago when this patient was a child. It relapsed. They did a retreatment. That didn't work. They did an apicoectomy. That didn't work. And at this point, the tooth is hopeless. It's got no facial plate. We're going to go ahead and remove this. And then we're gonna have to deal with grafting a defect. But when I remove these teeth, one of the things I'm looking at is what remains in the osteotomy. Now you can see the scarring from the previous surgeries. This is all apical scar. dense connective tissue. I cannot leave this. If I'm trying to graft bone, I cannot leave this. So the first thing we're going to do is we're going to take some curettes or a periosteal elevator, and I'm going to remove as much of the gross granulomatous tissue as I can. I don't want to be doing this with a laser. It will take me too long. So this is your combination case. You're taking your traditional surgical instruments, you're going to debride as much as you can, and then you're going to finish it with the laser. It'll take you a fraction of the time. All right, so now we're going to be able to scoop this right out. And just when I think I've pretty much have this thing debrided, I raise my flap up to make sure there's no pathology left. And what do I find? Remnants of the amalgam from the first apicoectomy. I cannot leave this. So this is a part of the scar tissue. So I'm going to dissect this out, and then I'm going to use the laser to remove any remnants of the amalgam that's still left in the bone. The soft tissue is a lot easier. You can do that generally with curettes or a periosteal elevator. But now I'm going to go in here and literally remove any remnants of pathology or unwanted material, in this case amalgam. And the thing that works best in my hand is a good ablative laser. Here's the remnant of the amalgam. I want to get down to good bone. Past the scarred bone, past the basal bone. Get a little bit of bleeding alongside there, and then when I'm sure that I've debrided this and I've gone up and down the walls, removed any last trace of granulation tissue, that's the point at which I'm going to be placing my graft. So all of my surgeries have a laser component, whether it's the sole instrument or whether it's an adjunctive instrument in the end to complete my debridement. Every one of these surgeries showed the correct settings and incorrect settings and its consequences on bone. So you want your bone to look like the right side. You do not want to see a discolored, denatured bone, carbonized bone. This is the death of bone cells, and regardless whether you're 1 millimeter away, 3 millimeters away, or 5 millimeters away, this is the kind of response that you want in your bone, and then you're going to get a good response in terms of rapid healing. And when I said there's always a thermalized zone, whether it's soft tissue or hard tissue, it's going to be about 8 to 15 microns. And that's fine, because that's a tiny, tiny zone. You're not thermalizing deeply through this, a millimeter or two, which would cause necrosis of the bone. And then I'm going to go through just a few of these real quickly, because I know we're running out of time. We're at the 45-minute time right now, and I'll go for another 5 minutes and come up with a conclusion. This is generally an all-day lecture or a multi-day lecture when we do these things, just to give you a little bit of taste of what we do. For example, I was going to extract this tooth, and I noted that when I opened and I looked at the CBCT scan, there was a huge residual cyst here. Why does this occur? If you extract a tooth and it has an apical granuloma, and you do not remove that granuloma, if the bone heals over it, you're going to get a residual cyst like this. And on cases like this, we're going to take our laser and literally go around here. I'm not going to show you the whole video, but we can expose this cyst and then literally I'll go to the end now. literally just remove it with a curette by opening up the bone without worrying about injuring the neurovascular bundle that's underneath. I want to show you this one last case before I sum everything up. This is in a hemangioma. These are the classic ones. When I was in my residency, the head of my program was an oral and maxillofacial surgeon, said, Dr. Miller, do not attempt to remove hemangiomas unless you want to be in the ER with them that night with a horrible bleeding episode. And for years, I was almost traumatized. I saw all these patients coming in with these huge lesions, ugly lesions on their lips. And I was afraid to do that until we looked at the possibility of using a laser. And this is an example of that. This one is about a 15 millimeter lip. It actually deformed this patient's upper lip and lower lip. It made a little indentation in the lower lip. But I want to show you how precise this is, because rather than using a scalpel, you don't use a scalpel in a blood vessel tumor. You have instant bleeding, but look at the precision with which we can trace this blood vessel tumor, and watch as I ablate through the margins of this. Right now I'm just circumscribing it just so I get a feel for where the margins of my resection are going to be. And as I start to make my way down through here, so let me skip ahead a little bit. You can actually see how I can feel the zone, the transition zone between the hemangioma and the healthy tissue. And this is at the end of the video, we're resecting the final part of this, but this is the final removal. I'm just getting down into the base of this. I'll skip ahead here, and now we're going to suture this up. This is the final suturing that takes place, and this is a 1-year post-op, and this is where the hemangioma was, and the defect in the lower lip. So we get phenomenal responses. We can do things that we were told we should not do or could not do with traditional surgical armamentarium. And we can do it safely, we can do it effectively, and we get beautiful clinical outcomes and patient outcomes for all of these procedures. Now, I wish we had more time. We're at the almost 15-minute mark. So I am going to turn this back to the conference organizer, and we will go ahead and start looking at the questions that were posted on the chat column. So I'll go to my end slide here. So let me just get to my summary here, which is lasers can be used to physically manipulate tissue through ablation, resection, and tissue sculpting. We control the hematologic response. We control the neurogenic lymphatic response, reduce postoperative swelling discomfort. We can induce faster regeneration by upregulating growth factors, on upregulating cell metabolism, and also recruiting certain types of cells. And we can control the biologic response that helps to create a more favorable clinical outcome. So someday I hope that I meet each of you in a normal conference where we have several hours or perhaps a half day, and in some cases a full day, to go through all the procedures that we can do, not just in oral surgery, but in periodontal surgery, endodontics, pros, and oral implantology. For those of you who would like to contact me, I leave you my email address here. If you ever have anything that you want to share with me, any questions about the use of lasers, you can do that. So I'm going to turn this back over to the conference organizer at this time, and we will go ahead and enter. Okay. Well, everyone, I hope you have enjoyed today's webinar. And what I'm going to do in the next 10-15 minutes is to answer some of the questions that have come in. The first question is from Dr. Kulkarni. Do we need to buy separate lasers for hard and soft tissue surgery? No, we do not. You can do soft tissue surgery with a hard tissue laser. You can actually tweak the settings. You can cut down on the water or even eliminate the water so it acts like a diode laser. However, you cannot use a diode laser for hard tissue surgery. You cannot ablate with it. Next question. What about all tissue laser at the time of surgery for bony procedures as well as soft tissue procedures? Again, as you witnessed in my webinar, both hard and soft tissue surgeries can be done. There are different tips that we use, different settings that we use, different combinations of water and air. And that's why we also give courses on this, because you need to have the settings and the tips available so you can perform it safely and effectively. You don't want to be using the wrong setting or wrong tip that actually damages tissue by carbonizing or vaporizing it if it's not appropriate. Next question from Dr. Swarna Prabha from Chennai, India, a place where I used to lecture every year. Hello to Chennai, India. Does the wavelength of the laser with the same active medium have an influence on the success of oral surgical procedures? Now, there are different wavelengths. There's a 2780 erbium chromium, there's 2940 erbium YAG, there's 9300, 9600, and 10600 CO2. So there are many hard tissue lasers. However, not all of them do exactly the same thing. You can tweak their settings enough so that they're very, very similar. However, there is a difference, for example, between erbium chromium and erbium YAG in the absorption of the wavelength into water-containing tissue. For example, the erbium YAG has a 300% greater absorption into water-containing tissue, and that is the reason why for erbium YAG you need to have your tip almost in contact mode with what you're doing. Now, that cuts down on visualization, and it also takes a little bit longer for me to do the procedures, because when I'm in contact and the laser wavelength is dissipating quickly, I have to spend a little bit more time. So I find that if you saw the distance that I could work in with the erbium chromium laser from Biolase Technologies, I have a way to better visualize and better prepare the material that I'm working on. Next question. Let's see. Can you tell the parameters for different procedures? Well, I can, but I'm going to need another 5 hours in a webinar to do that. So perhaps they can invite me back and I can actually give you settings for a lot of the procedures that we do. I also left my email address at the end of the webinar, so that if you want to contact me and ask me something specific about a procedure, I'll be happy to share my settings and tips with you. Next question. What is the laser setting for blood vasodilation? Can it be a diode only or erbium chromium? Now, vasodilation, you're talking about photobiomodulation, because vasodilation is different from coagulation. It's the opposite. So photobiomodulation, the release of nitric oxide, is going to be something you can do, but generally we do that with a soft tissue laser, and we generally do that with a wide, not a tip so much, but a wide wand, so that it covers a larger area. Because if you want vasodilation for the healing of a flap, it's very difficult, much more difficult to do with a handpiece with a tiny tip on it. You need a bigger spot size. And it's a very low setting as well. And I can, just email me, I can share those settings with you. What motion or technique of laser really suggests to minimize tissue tag formation while using the soft tissue diode laser? That's more difficult, because remember, cutting occurs through thermal coagulation of the tissue. So it's not a very precise thing. If your tip is clean, remember, as you're dragging it through, you'll find that epithelium starts to clog, it just starts to become attached to your tip. So my suggestion would be use a clean tip, and every time you see something attaching to it, just take a little bit of alcohol and a gauze, clean it off, and then you'll get fewer tissue tags if you do that. Next question for the root conditioning: what percentage of phosphoric acid or citric acid to use? How long do you leave it on? The old citric acid was very, very acidic. It was almost down to pH of 1 or 2. It was very acidic, and we would leave it on generally about 30 seconds to 1 minute. And the phosphoric acid is the same phosphoric acid that we use for teeth etching. It's a standard percentage. And it's not left on long. Remember, I'm doing two things with it. One, denaturing any potential bioburden and bacterial endotoxin that's on there. Plus, I'm opening up the dental tubules. You can do the same thing, by the way, with EDTA, because EDTA is used in endodontics and other procedures to clean off the smear layer, and it is acidic, so it etches a little bit on the root surface. It's not left long, but just enough to clean it and etch it. Cells do not attach to smooth surfaces. You want to etch your root surface in those procedures. Is the hematologic response in soft tissue laser the same effect as an all tissue laser? It is, but there's a higher thermal effect in a diode laser than there is in an all tissue laser, because we're able to direct it better with a hard tissue laser. But yes, the same effect, because it's still coagulation. Next question about ulcer removal, and I believe what is meant by that would probably be an aphthous ulcer. The AP is aphthous. Remember, we're not removing the aphthous ulcer. What we're doing is we're decontaminating it, because in most aphthous ulcers, the organism responsible for them is L-form streptococci. So by using the laser, we're actually getting a bactericidal kill. And then at the same time, we're also getting a neurogenic response by sealing off the C. afferent vessels in that, and a little bit of a lymphatic response. So I like, you can do that with a soft tissue laser, again, not in contact, not just above the tissue. And then you can do that with a hard tissue, all tissue laser, with the same effect by cutting down on the water and air and having more of a coagulative effect when you do that. Next question. Why did you use an erbium chromium for hemangioma? Why not a diode laser? Because, and there's a good reason for that, and that is I don't have a tactile sense with a diode laser. Now, some people will do that, and some people will go through and have to visualize, but I'll tell you that when you're doing that and you're coagulating heavily, it's very difficult to see your margins between your hemangioma and the otherwise healthy tissue. So when I'm using my flat chisel tip on the erbium chromium, I'm not just cutting through the tissue, I'm feeling it, because you can feel the difference. The soft tissue, the healthy soft tissue, is actually not as dense as the hemangioma. So I can actually work my way, I can feel my way along the border of that. So it's much more precise than a soft tissue laser. My good friend, Dr. Nuket Burke from Ankara. She's a wonderful laser dentist. In fact, she did some of the pioneering work on depigmentation. If you ever want to see a great presentation, Dr. Burke can really show you how to do that effectively with the erbium chromium laser. Let's see, can we use lasers for patients under aspirin or blood thinners without stopping? Absolutely, because why are we concerned with anticoagulants? Because of the bleeding perioperatively. And whether it's oral surgery or oral implantology, that's one of the problems that we have, control the bleeding. So lasers are great in just the right setting to coagulate those blood vessels, so we can do our surgery procedures very often without needing to have them stop their anticoagulants. The last question here: is it possible to remove any size of angiomas, or are there limits in some areas where there is a contraindication? Well, obviously, yes. If the hemangioma wraps around a critical structure, then you have to weigh the risks of resecting that critical structure. And the problem, of course, in lips is that the deeper you go, the larger the arterial flow. And you have to be prepared, if you do transect one of those larger arteries, to suture that vessel and stop it. Because if you don't, it's going to bleed through. It's going to continue to bleed for hours, and the patient's going to get all swollen. So when we're doing it, we're watching before we close. We look at the site for a few minutes to make sure there are no bleeders that are there. I wish we had more time. This, of course, was a little primer, a little way to show you some of the things, just a taste of some of the things that we do in oral surgery. The list is exhaustive. It takes me a half day to a full day to really get into just the procedures in oral surgery. And then we add to that periodontal surgery, endodontics, pediatric dentistry, pros, and finally my great love, which is oral implantology. And it will take me at least 2 full days to do a lecture and workshop using this particular wavelength and for the procedure that we do. So we've run out of time. Thank you so much for getting on your computers after a busy day or before a busy day, wherever you are in the world. And I hope to see you live as this pandemic winds down and we get back to life at normal ranges. And I'm starting to travel through the United States. I'm hoping at the beginning of the year, 2021, to start to return to all the places that I normally go to. We'll be returning to India, Abu Dhabi. I'm the head of the Maxi course in Cairo. I'll be doing work in Malta and many other countries, and I hope to see you all along the way. Thank you.